Good morning. So at the outset, I would like to thank Dr. Jayasri and KSOS for giving me this opportunity. So I'll be speaking about an association of greater significance, myopia and glaucoma. So we'll discuss about the background of myopia, the association, then why the association, what are the risk factors to be considered, and what are our challenges in front of us and the management strategies and few cases. So the thing is that the prevalence of myopia has been increasing from 2000 to and by 2050 about 52% is the prevalence of myopia. And among them is the 10% will go for higher myopia. It's mainly due to the change in the lifestyle at present. So the patients is showing myopic patients having a 2 to 4 times increased prevalence of glaucoma. And the stronger association is in the moderate to the high myopic group. And several population studies have been demonstrated the association of myopia and glaucoma. One of the studies is the Blue Mountains Eye Study. And the Aravind Comprehensive Eye Survey is another study which have demonstrated the association of the myopia. And all of the studies are showing the association is more with higher myopic patients. For each unit of 1 diopter increase in myopia, the risk of the glaucoma increases about 20% and most steeply in high degree myopia. Now, why the association? It is mainly due to the mechanical hypothesis, as we all know. It is due to the thinner sclera, thinner lamina cribrosa, and the lesser support there, along with the axial elongation, which causes the tilt, the torsion of the optic nerve head. Again, non-distensible retinal ganglion cells, which are kept under the mechanical stretch and all, plus the vascular compromise, which result in the more or increased susceptibility to the optic nerve damage in myopic patients. So what are the risk factors to be considered while we start treatment? One is the high, whether the patient is having a high myopia, more risk, longer axial length, again the level of IOP, again family history of glaucoma, thinner corneas, and the optic disc still can staphyloma and all is more vulnerable for structural damage. So those patients should give more consideration. So what are our challenges? Again, we have the diagnostic challenges are there, whether this patient is myopia or not. And again, in the management strategies also we are having many challenges. So what are the diagnostic challenges? First of all, the IOP measurement limitations. Again, the myopic patients are having thinner corneas and usually the IOP is underestimated and sometimes the IOP is usually always normal. Can be a normal tension glaucoma per se. And usually myopic patients must have undergone this LASIK procedure. The history of any refractive surgery is very important because the corneal biomechanics is all usually altered in post-LASIK myopes. And hence the Goldman's applanation tonometry may be less accurate. And this high myopes are having fluctuating IOPs and the younger myopes are having higher nocturnal supine IOP elevation. So the fluctuation factor is also there in myopes. So the better thing would be you should consider the corneal hysteresis in these patients. And it is actually a measure of the cornea's viscoelastic property. And the myopes are usually having lower corneal hysteresis. And this lower hysteresis are more there's increased risk of glaucoma in those patients. So better would be either a dynamic contour tonometry or an ocular response analyzer, which is independent of the corneal viscoelastic property. Then again, the structural challenges. Again, the altered disc morphology in these patients, difficulty in assessing the cup disc ratio. Again, the essential rule violation, the peripapillary atrophy, again, bring us to again a confused situation. Usually the disc is a larger disc, the size with increased area, more oval shape, and the disc is usually tilted, torted, and due to the oblique insertion. And the nasalizations of vessels also will be there due to the longer axial length. The cup disc ratio, again, the temporal thinning is more common, which may appear as pseudoglaucomatous. And the cup is usually shallow, diffuse cupping. So which may again confuse us whether the cup is increased or whether it is glaucomatous or not. So what is the solution to this problem is that rather than looking the ratio, better give emphasis on the size of the neuroretinal rim, integrity. And usually you should follow the contour cupping rather than seeing the color of the cup. See for the proper contour cupping and whether there is a new NRR thinning is developing or not. And watch for any disc hemorrhages occurring. That is solution to this problem. Again, beta peripapillary atrophy is more associated with a higher risk of glaucoma progression. And this peripapillary atrophy often results in this OCT segmentation errors, which again make confusing. Posterior cephaloma causes localized, again, diffuse RNFL thinning, distorted OCT maps, alters the RNFL and the ganglion cell complex symmetry, and causes atypical visual field effects. Again, the imaging, the visual field testing is again a challenge in the patient with myopia because high myopia affects the threshold sensitivity, and the defects which favor myopia will be more a supratemporal quadrant defects and enlarged blind spots more favor for a myopia. And the defects which favor glaucoma is the nasal step, arcuate pattern, and the paracentral scotomas more favor for the glaucoma. Some of the patients are misdiagnosed seeing these visual field defects, so hence most of the patients may be taking unnecessary treatment. So in those cases, don't go for a single visual field, go for a repeat visual field and see for the progression and the pattern consistency, and the trend analysis is a better way. OCT RNFL, again, usually the normative database is excluding the high myopes. So hence, usually it is shown as the wrong values. And the average RNFL thickness decreases with increased axial length. So high myopia already has a lesser RNFL even without glaucoma. So this also should be taken consideration while seeing the RNFL map. The OCT artifacts, the peripapillary atrophy causes segmentation errors, poor image quality, and the signal dropout in cephallomas. Again, there is a shift, temporal shift of the RNFL bundles due to the disc tilt. Again, the axial length can cause magnification errors, and the incorrect scan centration due to the altered disc morphology all will result in difficulties in OCT interpretation. Again, high myopes, usually the values are out, hence it shows as the red disease. So all high myopes, all the reds are not the red properly. It is the false positive which you see in high myopes. So in these patients, a better reliable measurement would be the assessing the ganglion cell complex because it is less affected by the peripapillary atrophy and the disc tilt, and more reproducibility with the lesser segmentation errors and the better agreement with the visual field defects. So that would be a better option in myopic patients. But still the macula is susceptible to changes due to the cephaloma formation and traction and all. And the positive temporal raphe sign is more suggestive of glaucomatous patients. So what would be the solution to this? We should compare the serial OCTs, see for the true RNFL thinning, consistent patterns, and again the progression analysis would be a better option. And the clinical examination also, you should, as I told you, trust in NRR there rather than the ratio. Look for any focal or a new notching, disc hemorrhages, and consider the axial length and the degree of myopia always while interpreting an RNFL map. And don't overdiagnose because many myopic abnormalities are usually stable and they are non-glaucomatous. So management would be establish a baseline, go for serial disc photos and visual fields, and the macular GCC would be a better option. So emphasize serial monitoring rather than a single test. Surgery, again, there's a reduced scleral rigidity and the risk of hypertony in younger myopic patients. So go for a tighter closure with releasable sutures with judicious use of MMC. And in myopes, this minimally invasive glaucoma surgery would be a better option. We have new promising tools are there. This angiography methods are there which can detect the focal defects in the peripapillary retinal perfusion around the optic nerves, and the study conducted at the Giridhar Eye Hospital has concluded that the measurement of the peripapillary superficial vascular density has a greater discriminatory ability than that of the macular area. So newer tools are there to differentiate high myopia. Again, a word about artificial intelligence that is now being applied to large databases of fundus photographs and OCT scans to develop deep learning algorithms which may help to detect glaucoma in high myopes. So it's just an example. A 50-year-old patient, a very high myopic patient, he has been actually classified as ocular hypertension. He's on latanoprost with a 20 IOP in both eyes. Optic disc show very tilted, ovoid, pronounced peripapillary atrophy in the left eye. And again, RNFL is showing thinning of the RNFL map, is severe thinning of the ganglion cell maps. but the visual fields actually were stable with an enlarged blind spots both eyes. So with the repeated visual field showed only the enlarged blind spot. So in this patient, actually, the treatment was again, we did not add any drug to this patient and the treatment was continued. Another patient with the -8 in the right eye and -7 in the left eye, he was diagnosed as a normal tension glaucoma, myopia was stable. Again, the optic disc was showing slightly tilt cup disc with mild peripapillary atrophy. But in this patient, actually, he showed a typical thinning of the RNFL superior thinning with the inferior arcuate scotoma. And you can see that the visual field has been progressed and is more progressing towards the fixation. So in these type of patients, we should add the drug. So the key takeaways would be the glaucoma is usually associated with moderate to high myopia, and myopia often creates multiple artifacts. So hence the longitudinal follow-up is the key to high myopia. And hence the diagnosis should be clinical judgment and the progression monitoring and not isolated test. Thank you.